The recording will be posted on the committee's webpage after the meeting. And for everyone's reference, today's agenda can be found under the first tab in the meeting materials. And as a reminder for everyone, please remember to use the primary care committee email inbox to send updates or questions. And if you are not a member of the committee, please turn your camera off. And now I'll turn it over to Chair Judy Zernanthal to call the meeting to order.
Thanks. And I'm not allowed to share my video, so I will just keep talking. But I'm going to start with the overview of the agenda. Then we'll have roll call. We'll vote to approve the meeting summary of our October meeting. Then we'll have public comment. Next, Kaylee Dufresne and Hannah Hartman from HCA are going to present on primary care expenditures and non-claims-based spending. And at the end of their presentation, Shane from the Center for Evidence-Based Policy is going to lead the discussion on non-claims-based definitions. Shane Mofford is also going to provide an overview of key considerations and differences between the broad and narrow definitions of primary care. And we're going to be voting at the end of that discussion. So I encourage committee members to ask questions and provide feedback to help facilitate our discussion. And thanks for all your time and efforts. And I will, and one other thing I wanted to update, Jean Marie has had a healthy baby boy and is enjoying her maternity leave, for those of you that were wondering. And now I'm going to start roll call, and I'm going to call on members by first name in the order listed on the agenda, which is alphabetical by last name. When I call on you, please unmute your microphone, let us know that you're here, and then mute again. So Crystal?
Here, thanks.
Was just trying again to see if I could do video, but it's okay. Off camera is nice. Sharon Brown?
Here, I was also trying to do video, Dr. Zerson, but it wasn't allowing me to, but I'm here.
Okay, it's all fine. Tony, I think he is not here. He might pop in for a short bit between patients. Michelle?
Hi, I'm here.
Great. Tracy?
I'm here, thanks.
Thank you. David?
Hello, I'm here.
DC is not able to attend. Sharon Alaranta? Gregory?
Chandra here.
Oh, hey, Greg. Thanks. Chandra?
I'm here.
Meg?
I'm here.
Cheryl? I think she might be coming late. Lon?
Here.
Katina is also unable to attend. Mandy?
I'm here.
Great. Jonathan?
Here.
Excellent. Sarah? Linda most likely can't attend, so I don't know if she's here. And Sean is also unable to attend, so Stacy? Ginny?
Hi, this is Jenny.
Great, I saw you on, and Maddie.
I am here.
Excellent. So I'm going to turn it back over to Stacy, who will facilitate review of the October meeting summary. And I'll try and make my poor dog be quiet.
Thank you, Judy. So please join me in turning to the meeting summary and the meeting materials. The recording of the last meeting is posted on our webpage. Is there any discussion of the meeting summary or any proposed changes? And if not, would someone like to make a motion to accept the summary?
Motion to accept.
Second.
Thank you. Thank you. Any opposed? All right. So the October 2023 meeting summary is approved by consensus. And next we will open the floor for public comment. If a member of the public wishes to provide public comment, please raise your hand. When you are called upon, please state your name and affiliation, if any, before speaking. Please do not raise your hand more than once. This helps to ensure that everyone has a chance to speak. And you are also welcome to provide comments in writing via email at any time. And please remember that this is the time for public comments, so any Q&A session should, any Q&A sessions during the meeting are times for committee members to ask questions. So I'll just give it a minute here in case anyone would like to provide public comment. And so I do not see any raised hands. Next I'd like to introduce Kaylee Dufresne and Hannah Hartman, who will now present on primary care expenditures and non-claims-based spending. And Shane will be leading discussion on the non-claims-based definitions at the end of the presentation.
Thank you so much. Can everyone hear me okay?
Yes.
Okay, great. This is Hannah Hartman. I work in the policy division at the Healthcare Authority. I'm on the value-based purchasing team, and I'm going to talk to you today about primary care expenditures and non-claims-based spending. So we can go to the next slide. Perfect. So just a little overview of where we're going with this. I'll give you some context. I'll give you an update on primary care spending, both in 2022 and over time. At that point, I'll pause for questions on the first half, and then we'll go on to claims versus non-claim spending, the definitions of non-claim spending that we currently have, and then Shane will step in to facilitate a discussion about how that might change in the future. So a little bit of context to help orient us. The legislature set a goal of spending 12% of total healthcare dollars on primary care. And to achieve this goal, we need a shared definition of primary care and a shared understanding of how we're measuring primary care spending. So this committee is in the process of revising HCA's definitions of primary care spending. My understanding is that the definition of claims-based spending is already complete. And now we're moving on to the definition of non-claims-based spending. So I'm here to tell you a little bit about what we've learned about what our contracted plans are spending on primary care to help inform that non-claims-based discussion. Next slide. So when we look at this chart of primary care spending by sector, just some caveats about the data. So these bars are self-reported information directly from our contracted plans. They are using the narrow definitions of both providers and services, and they include both claims and non-claim spending. And all the information here is actually just for HCA contracted business. So when it says all commercial, that's referring to all the commercial plans that HCA contracts with, including public and school employees and Cascade Select. And that overall covers around a quarter of the Washington health insurance market. So when we look at the Medicaid column, it's obviously the highest. Medicaid is clocking in at around 9.5% of their total spending on primary care. Then when we go to all commercial, which as I said is primarily, well, it's completely the public and school employee benefits plans, as well as Cascade Select, that's around 6.7%. And then the weighted average is closer to the Medicaid number because there are so many more people covered by Medicaid, and it's at 8.8% of total spending in primary care. Next slide. When we break that down by plan, you can actually see the spread across plans within each category. So for example, in Medicaid, the highest performing plan is at 11.3% of their dollars in primary care, and the lowest performing is at 4.6%. PEB and SEB are a little bit more in the middle, a little bit closer together in the different plan performances. And then Cascade Select is a little bit lower down. I do just want to note though with Cascade Select that it has, it's just getting started just in its first couple of years. It has low enrollment right now because again, it's just launched. So it's a little too soon to take away any big lessons there, but I wanted to include it in the display. Next slide. When we zoom out from 2022 and look at the trend over time, you can see there's an overall trend of decreasing primary care spending. And I'll just quickly note that there are a few data integrity issues with the 2019 and 2020 numbers in our self-reported files. So those are marked with an orange star where there are issues. But overall, we are seeing a kind of a decrease. And that downward trend could be a result of the rising cost of other types of care, the decrease in primary care utilization during the pandemic. In Medicaid specifically, it might have to do with the sharp spike in enrollment during the public health emergency. But all of that is speculation. We're not entirely sure what's driving that downward trend. Next slide. And before I pause for questions, I'll just note that back in 2019, the Office of Financial Management commissioned a report on primary care spending for 2018. That report by OnPoint used information from the All Payer Claims Database, or APCD. And that analysis has been updated for 2019 and 2020, but not yet for 2021 and 2022. We're still waiting on those numbers. And this group has recommended using the APCD for claims-based spending going forward. So if you have looked at that report, or if you remember the numbers from that report, you might be thinking, whoa, the numbers on these slides are much, much higher than what I saw in that report. And that is because the OFM report only included claims-based spending. And these numbers include both claims and non-claims. So when you set aside the non-claim spending and just compare claim to claim for 2019 and 2020, there's still a slight discrepancy where the self-report is a little bit higher than the OFM numbers, but it's not a very large discrepancy. And once we have numbers, like I said, 2019 and 2020 do have some data integrity issues with the self-report. So once we have the 2021 and 2022 OnPoint analysis, we should be able to compare a little better apples to apples for those 2 years and draw some better conclusions. So this is the end of section 1. So I'll pause here for questions. I think I see something in the Q&A. Cheryl asked about differences in primary care spending between age groups. We do not have that information in the self-report that we get. We just ask about, we have numbers of sick visits and well visits, but we don't have it broken down by the age of the patient, unfortunately. Are there any other questions on this first half? Okay, hearing none. So moving on to our discussion of claims and non-claim spending. First of all, what are these things? So claims-based spending is fee-for-service, essentially. The provider performs a service, submit the claim, the insurer pays it, that's it. The non-claim spending includes different types of spending that can happen outside of the claims system, such as capitated payments, like per member per month, to providers or care coordinators, health IT and workforce investments, incentives or bonuses for quality performance, and shared savings payments. Next slide. So when we look at the 2022 numbers, based on current definitions, about half of Medicaid primary care spending is distributed through claims. So the range of within plans is 43 to 64% are in claims, and the remainder is in non-claims. And that's compared to around 96 to 100% in claims in HCA-sponsored commercial plans. So we suspect that the much higher rate of non-claim spending in Medicaid is due to the high proportion of patients that are attributed to federally qualified health centers, or FQHCs. And about 40% of Medicaid covered lives are attributed to FQHCs, which is a much higher rate than in the commercial population. And FQHCs tend to have really robust non-claims-based billing capabilities. So we'll move on now to 3 slides that show the definitions of non-claim spending. And these show the exact, like the language on the slide is the exact language that the plans see in the non-claims spending template that they get every year. And I want to note that BAILIT presented to this group a few months ago, and they had some recommended categories that are comparable to the ones that we use. So the first category is capitated, subcapitated, or salaried expenditures. And that might be a PMPM or a salary paid to a provider for each person that they care for. We also have per member per month payments for non-billable activities. So that might be a PMPM or a fixed dollar amount for things like care coordination, behavioral health integration, things like that. Next slide. Then for patient-centered primary care homes or medical homes, If the plan is offering this, it's typically a per member per month payment based on a practice's PCMH level. Plans might also offer health IT funding, so payments to support a rural provider in transitioning from paper to electronic health records or something along those lines. Workforce, so payments for the salary of one or more FTE at a practice, or potentially for staff training and development. And the last slide of definitions includes provider incentives. So those are typically quality bonuses or shared savings from an APM, and other, which is where we let the plans tell us what we've missed. So on our last slide here, it's just a summary of all those different category types. And unless there's any questions from me, this is where I'll pass it over to Shane to facilitate the discussion. I see a hand up, David.
Yes, hi, Hannah. For the self-report, is that the information that plans submitted in response to last year's Transparency Board data request?
I don't believe so. I believe we send out a template for primary care expenditures every summer in July, but someone correct me if I'm wrong about that, and those are the same thing.
Oh, they are different. Great question, David. So yeah, this is a little bit of a different data source. As part of our contracts with all of our carriers locally, we want to measure this year over year. So we've been asking for this reporting just as part of our normal contracts with our carriers since, I believe, 2019. So that's this self-reported data source. We think it matches reasonably well with what we're seeing from OnPoint and others. Self-report, typically ends up with a little bit higher reporting than what our claims data is showing, but claims to claims comparison, like Hannah said, is pretty comparable. So slightly different than the Cost Transparency Board asked last year, but we wanted to share this comparable data source that HCA has at our fingertips.
Got it. Thanks, Kate. I have one more question if nobody else has a question.
Go for it.
It sounded like you were saying that the claims-based tally that you all ran recently is roughly equivalent to OFM's 4%, I think they got. Did I understand that right?
Yes. So the claims-based for 2019 and 2020, those are the only 2 years where we have both the OFM report and the self-report numbers that we can compare. And in those 2 years, the claims tally is fairly similar. It's a little higher in the self-report, but not by much.
Okay. And neither one of those is using the narrow and broad definitions that we're discussing today. Is that correct?
I believe they're both using the old narrow definition of both providers and services.
Okay, thank you.
Mm-hmm. Mandy?
So with the non-claims, what is the response rate? I mean, is everyone responding? Is everyone required to respond? Or what's the response rate among the plans?
Great question. All of the plans are responding because they are all required to respond.
Okay.
Yeah. Shane?
All right. Well, I just want to take a quick step back and make sure that we're all on the same page and connect the dots here before we solicit any additional feedback on this process. So the progress that you've made to date, you have really provided recommendations on, and we have a camera. Well, I might be the only one today though, so here we are. So the progress you've made to date includes developing recommendations on the reporting process, which Hannah already mentioned. So you have voted to support a process where HCA is actually calculating the claims-based expenditure and plans would self-report the non-claims-based expenditure. This this presentation that was shared today, I think is really great because it really illustrated a piece that's been missing today, which is the impact of that non-claims-based expenditure. And you can see that it's non-trivial. It's for the Medicaid population actually starting to approach that 12% target. And you might keep that in mind when you're thinking about Do we use the broad or the narrow definition? Because obviously one's going to put you even closer to already being at that 12%. The other part of your work that you've completed is around the definitional aspects. So you've defined the claims-based. In terms of what we've done for defining the non-claims-based, really there was a set of principles that you all voted to support for non-claims-based. You also voted to support a process that stratified the expenditures based off of type of payment, which you can see the categories that are in current reporting now. And also, as Hannah mentioned, these are relatively well aligned with what you saw as recommendations from some of the national work that had been done, which Michael Baylett had presented on several months ago. So the punchline here is that you've really fleshed out a process, and where we're at today is that we have operational processes from HCA that are very well aligned with the recommendations you've made, and that are well aligned with the lessons learned and some of the best practices that have been eliminated based off of national work. So the question that I have for you today is based off of what you're seeing in terms of what's being reported, the expenditures. Is there anything that stands out that might be a potential gap that you would want to identify for HCA to consider in future reporting requirements? I think the comment from Dr. Morelli was an interesting one about having the ability to report based off of different population stratifications. Would you all like to comment on that, or potentially raise any other gaps that you perceive in the current reporting capabilities that we should explore closing in as part of future requirements? Dr. Morelli?
Yeah, hey Shane, thanks. Oh, I maybe can put my camera on. Let's see. I think I have the ability. Oh, okay.
I could use a friend, so it's great.
Hi, everybody. So thanks. Yeah, obviously I'm a pediatrician, but I am really interested in does it look different? Because I think it may actually, we may be spending more in peds on primary care just by the nature of who we're taking care of. Versus like in our geriatric population. So I think it would be really interesting to look at it through standard age bands, and we could do, work offline. There's lots of different standards that we could think about adopting. We don't have to reinvent the wheel there at all, but I think if others are interested, that it really does look quite differently depending on the age of the population you're taking care of. And then I thank you for connecting dots for me. I hadn't really put together the fact that the Medicaid non-claims look so high because of the ways FQHCs are financed. And I think for our work, it will be important to pull that out, which it sounds like we already can do, if I understood. Because if you look at whether I'm getting care in an FQHC or from anybody else, not FQHC, and I'm on Medicaid, the spend is really different, and and consequently potentially the care is really different. So I feel that would be really important as well.
I will add just a quick note that the OFM report did break it down by age. And the update that we had when we reran that did also, and we are planning on using the old definition one more time to give us a little more, especially since 2020 was such a weird blip. And so the APCD is running that now. We'll hopefully have it early next year to get another sort of look at roughly where we are, not with our new definition, but with the old one, to give us some data points to trend. And I think that'll also do kids, but that's a good point for us moving forward to think about age breakdowns. Tracy? And I don't know, it's a good question. We'll have to go back about the pulling out the FQs and what that might look like.
Cheryl's question or comment made me think about obstetrics. Can you remind me where we put obstetrics? Are they excluded?
They're in the broad definition.
Mm-hmm.
Yeah. So not in this first part of narrow
Okay.
No,
So-
actually, I don't remember, Hannah. Was your stuff broad or narrow or both?
I was just sort of curious in general about, like Cheryl was saying about the spend on pediatrics, what we spend on obstetrics, both in family medicine and OB, but just more of a, just trying to remember how we defined it.
I'm not familiar with the updated definitions, but I believe that that obstetrics was excluded from the narrow definition, the old narrow definition of claims. And that's what I used for these slides. So obstetrics is not included.
And then I think this would follow on, but so for example, my family medicine docs that are doing C-sections or delivering babies, because of it's claims based, it pulls out the type. So it's not just because they're dropping the claim in their family medicine that's not included, but it pulls it out by the code. Is that right?
I'm not sure I understand your question. I'm sorry.
I was just trying to remember if it's excluded by category of provider or by what they're doing, since we have family medicine docs that do obstetrics.
It's both. So it's the category of provider and the category of services by like the claim, the billing code.
Okay.
So the charts I was showing are both the narrow provider list and the narrow list of billing codes.
Okay, thank you.
Yeah.
Are there any other questions, comments, reactions to what you saw? Okay, well, two last points on this. The first is that what we're going to do next is discuss whether or not we would use the broad or the narrow definition, and this would impact the non-claims-based spending as well, because non-claims-based spending that's attributable to a provider that's not included in the definition would obviously be excluded, or vice versa. So just keep in mind that both pieces would move, not just the claims-based, even though you might think that it's contrary to that. The second piece is that while things are generally aligned for the non-claims-based stratification, by aligned I mean with what we heard would be best practice based off of work that Milbank has done that was reported by Michael Baylett, and also some of the lessons learned from Oregon, which you might remember they came in and gave a pretty detailed overview of their non-claims-based collection process and some of the lessons they learned. So it's all true that things are quite well aligned. There are some areas where there might be future refinement at a pretty granular level, such as thinking through how to isolate just the primary care component of some of the episode-based payments. So for example, payments for a knee replacement that are made at a bundle level, how do you capture any primary care component of that? But really that's in the weeds. I think that the key takeaway here is that the process and the infrastructure you have in place with some minor modifications, it's going to be really well aligned with the direction that this group has provided. So that'll really have you off and running quickly into 2024 with the next data call. Just one last check for any other comments or reactions to non-claims, please. Crystal?
Yeah, I have a question and it, just to confirm. So I know a lot of the community behavioral health payments are under capitated models. Have those already been filtered out based on our other provider filters?
Haley, can you speak to that one?
Yeah, sure. Yeah, Crystal, good question. I am gonna look to Shane a little bit, who's a little more in the weeds on some of these definitions. I would assume that both the narrow definition of services and of provider types would mean that that spend was excluded from what we presented today.
Thank you.
Yeah, and actually, in just a moment here, I'll pull up a slide that has the difference in which provider types are included in narrow and broad, and that can help illuminate all of the differences, not just that. So you'll see that in a moment. All right, well, if there are no other questions, why don't we go ahead and keep moving to the next section, please? I believe this is just a caveat slide. If you're interested in some of the caveats, feel free to review the materials. Next slide, please. All right, so we are going to be talking again about the broad versus narrow definition. Just a heads up, we will ask you to vote. This is a really substantive policy, and I think the fun thing about it is that this is really one of the last pieces definitionally. You have the claims code set, the providers and the locations already nailed down. You have the process for reporting there nailed down. But we do need to select either broad or narrow. And the reason for that is because ultimately all of this policy leads to a requirement for plans to increase their primary care spending until they hit the 12% target. And you can't have two standards for that, because one would be, you can't enforce two simultaneous standards. So this will be really wrapping up a lot of the definitional component of your work. And then, just to talk about briefly where we're going next, we have no meeting in December. And then in the first part of 2024, we'll really be focused on two things. Those two things are now that we have a reporting mechanism, now that we have a definition for measuring, and we already have a standard of 12%, what is the incremental progress that's expected annually? And then the second piece of that is what are the enforcement mechanisms for the policy, or how do you encourage plans to comply with the requirement to increase expending or increase the primary care expenditure ratio over time? So Sharon, I see you have a question.
Yeah, I apologize. I had to step out for a quick minute. Is there a recommendation on which definition?
The broad versus narrow?
Yes.
We're actually going to review a few of the considerations that feed into that, and then we'll vote on it afterwards. So you're one step ahead of us.
That's unusual, so thank you.
Fair enough. All right, if you could go to the next slide, please. So again, this is just part of the primary care definition, and it's exciting to be wrapping this piece up. If you could go to the next slide. All right, so this slide, this is getting at some of the questions that were asked in the last section. This slide focuses on just the differences between the narrow and broad definition, so that you can see really explicitly, for example, if you vote to go with the narrow definition, these provider types would not be included in the measurement process, or they would only be in the denominator and not in the numerator. I'm going to leave it here for just a second, so you can all, I know you all have seen this multiple times, but just give you a second to reabsorb before we move on to asking you to vote on it. And we're going to be talking about some of the considerations that potentially intersect with who you're including, who you're not. It's also in your materials, so feel free to reference that. David?
Yes, yeah, I think I'm one step behind. I just want to make sure I'm where you want me to be. So you're not talking about applying narrow and broad to non-claims. We left the non-claims issue behind, and now we're talking about overall, are we using narrow versus broad? Is that right?
Yes, this is overall, so it would apply to both. So this is how you're defining primary care, which is both for claims-based and non-claims-based.
Okay, and I think at one point you had mentioned there might be some analysis where the narrow and broad definitions are applied, and we can see what the percentage difference is between the two. Have we seen that before?
I think we have a slide on it next. Maybe we could go ahead and go forward one. So not behind, you are also ahead. I have this information here, and then we also have an anecdote that's from the
Shane, I think you just muted yourself.
Yes, we lost
thank
you.
Sorry. So this is covering the the OFM's 2019 report. This is showing you across different market sectors the expenditure for claims based only when you use the narrow versus the broad definition. Your narrow and broad definitions are relatively similar, but not exactly the same. So getting back to your question about the analysis, as you may recall, we did run an analysis to answer some questions about, well, what is the underlying utilization of some of these codes? Should we even be including them in our definition of primary care? And that analysis showed that there was approximately a 0.75 to 1% difference between the broad and narrow definition. So it's relatively similar to the results you see here, although these obviously vary by market sector. So I think these are a relatively reasonable approximation of what you would expect, but ultimately the piece that we don't have, which we just saw is quite impactful, is the non-claims based expenditure under the broader narrow definition. And we won't have that until the next reporting cycle where, well, we won't have that really ever because we're only going to have one definition that's applied in the next reporting cycle. So I would use this as
wait on the questions. This is Judy. I think maybe let's wait on the questions until you get through the rest of your slides, because I think there will be a lot of discussion about this.
Yeah, absolutely. Okay, we'll come back. All right, and if you want to go to the next slide, please. So these are some of the key considerations that have come up either in conversation as we've talked about different aspects of the definition and what the implication of using either the broad or the narrow definition would be, or even thinking about just taking a step back from a policy perspective, like how does the math work out? So kind of the three big considerations, and you all may have more in conversation, so please raise them, but the narrow definition is more closely aligned with the definitions used in other states, which includes states that were used as a benchmark when setting the 12% primary care expenditure ratio target in statute. So the fact that you already have a statistic that you're working towards aligning with the definition may make sense because it's a little, it's not a little, it's just more comparable. I think maybe a good example from one of the slides you saw earlier is that Medicaid, even at the narrow definition, was a little over 9%, I believe, which is already starting to approach the 12%, and it would be you know, a percent or more higher if you included the broad definition. So you know, it's something to keep in mind. That actually gets at the second point too, which is that the narrow definition will require greater primary care investment to hit the 12% target. Obviously, the broader you define primary care, the higher your statistic will be, and the smaller the gap towards the 12%. This last point is something that came up in conversations with you all as we were talking about the definition development. So the broad definition may not directly support team-based care. However, if you take a step back and think about it, the narrow definition, it can still be used to support team-based care due to the overall increased investment in primary care. But it's certainly worth considering that when payers are reacting to the policy of having to hit a target and there's a specific definition, financial policy is obviously going to follow that. But there's really two competing dynamics here: is the total volume of funding that's going to primary care versus you know, which specific codes are getting reimbursement or however else that's rolled out by plans. So those were really the three key considerations. I do want to pause here and just a little solicit some more feedback before we get to voting. Is like, what are other thoughts or considerations regarding broad or narrow that either I haven't captured here that you've heard come up or that you think are relevant for you and your peers to consider before we vote? David?
Yeah, I'm trying to think through the economics of this, Shane. So this is more a question for you and the group as to how other people would be thinking about this. But if, for example, we imagine that spending doesn't decrease in a non-primary care setting, but there's legislation to increase spending in primary care, that's going to increase the total cost of care, which in a commercial setting will increase premiums for beneficiaries. In a Medicaid setting, I'm not exactly sure what happens because HCA has to justify rates to CMS based on historical experience, and HCA may have some leeway to say there's a legislated increase of X percent, but it gets a little more complicated. Have you thought through those dynamics or have any insight on that?
Well, I think the challenge with answering that is that there's a lot of different ways that you can support increasing primary care expenditure. I don't know if you remember, but it's a few months back, we tried to create a 4-quadrant framework that highlighted, well, workforce, if you have more people participating, that's more utilization. Even if you don't increase your reimbursement rates, that's more utilization of primary care that's going to boost expenditures, or it boosts that expenditure ratio. Obviously, there's at least some hope that, kind of the catalyst for the policy presumably is that engagement with primary care is going to have a positive impact on your health. And that potentially could reduce expenditure in other areas, reduce utilization of ER, reduced utilization of inpatient hospitals. But ultimately, plans have flexibility in figuring out how they're going to hit that target. And there's a lot of different ways to do that. And so it's difficult to say prospectively how that would happen. I know that we do have several members of plans that would be faced with addressing that dynamic. And I know some of you have some lessons learned from other states. I wonder if you'd be willing to speak to how you think this would play out in reality and what some of the potential challenges might be. Fair enough. Okay, so, I don't have a great answer for you there. I think that part of this really is it's requiring a prioritization of focus on primary care that maybe isn't there today, and part of that's going to be spending differently, not necessarily spending more, but how that pans out at the delivery level across all of the different provider types is very difficult to predict. And I think the reality is also that there are a lot of other policies that are going to intersect with this. So, for example, there's been significant investment in hospitals through provider fee, if I am understanding that correctly. And that obviously is going to move the denominator, which is going to make it even harder to grow 1% for primary care. So a lot of interactions and no concrete answer for you, unfortunately.
Yeah, thanks.
Mandy?
So I have a question. This may wind up being a question more for On Point. Because I don't remember when we did the original OFM report, I don't think we ever looked at what was really making up that difference between the narrow and the broad percents. And so I guess the question would be is how much of that difference is attributed to OBGYN? I don't think we looked at that in the first report. We may have had On Point look at it, but I don't remember. Judy, do you?
Yeah, I don't think we did. I don't recall ever seeing that.
I don't think we paid attention at the time, but it might be good, just a piece of information for us to know is like, of that difference between the narrow and the broad, what is making up that? Is there something that is making up that big difference, and is it OBGYN?
Yeah, I think that's a good call out, and I think potentially because that is the more reimbursed service if we went back to sort of who's who's in the broad and not in the narrow, I don't know. I would guess that that is a chunk of that.
Yeah.
Any other questions or observations about the differences between broad and narrow that you think, again, are relevant for consideration before we move to voting? You could go to the next slide, please. And Judy, I'm gonna kick it over to you to do all the things.
Yes. So I think if there's additional discussion we want to have on this, now is the time. I know that this is different than the initial approach when we continued the narrow and broad definitions earlier this year when we made them. But getting down into the details of how do we operationalize this and what does it look like, I personally think it makes more sense to just have a narrow definition for some of the reasons that Shane mentioned. And so we want to have that discussion and vote with you guys and see if people feel differently than that, then we should chit chat about it. And if we want to vote, then we can vote. So Greg? And Greg, you might be on mute if you're talking.
Sorry. Yeah, yeah, can you hear me?
Yes.
I'm interested, Judy, in a little bit more of your thought on why narrow makes sense to you.
Yeah, so I think narrow will get us to greater investment in primary care. As you saw from our first presentation today, if we include the non-claims-based data with the claims-based data, and granted there's a little caveat of the claims-based tend to be slightly inflated, but we are starting to get pretty close to 12%. And my personal view is that I don't think it feels like we're at 12% for providers in the trenches. And so we did have this long conversation about OB versus not to Mandy's earlier question. I think that if we really want to focus, doing this narrow definition is probably the right way to go. At some point in the future, we could change it. But if we're trying to think about the sort of what do we want changed from what's present, I think the most impact will happen with the narrow definition to start with.
Thank you.
Tracy?
I agree with all that, and just wanted to add another thing I think is important is that the narrow definition most closely matches what we sent the 12% on. And if we had used a different definition, that goal could have been 14 or 15%. So it seems important to me that we keep those the same. Otherwise, we're probably not making the appropriate level of investment.
Thanks. Mandy?
So because it was bugging me, so I pulled up the old report. So I did mention in the first report that, so if we don't include OBGYN, we'll have an age effect, because what we were surmising was that a lot of the primary care visits for the younger working age adults were being, that they were probably a substantial proportion of them are OBGYN. So if we don't include it, we're just going to see some age changes happen within like the percents if we break things down by age. So I think that's something to consider.
Okay. Yeah, there will be, I think, some population of younger women that go to OBs, to your point. And so they may not be captured in terms of services here. And I think I think it goes back to that investment question about where the resources go or don't go. And I'll say this is also our first go round at this. We're going to have more data towards the end of next year on both the claims and non-claims based, and we'll have further analysis that we can think some more about, do we tweak it differently or is this it? So so yes, thanks. Crystal?
The only thought I would add in line with what you were saying is, you know, this is complicated work that we've been kind of all engaged in for quite some time now. And even in the beginning, I remember the discussions of why the broad, why the narrow. So just in a spirit of trying to keep things simple, even from that perspective, if we just have one narrow, fairly aligned with what other states are doing, it might be an easier message. Otherwise, you have these why questions to answer that I don't know that we have a great reason for if we have both definitions. So just my support for just the narrow as well.
Yeah, it definitely makes some complications, because if the broad ends up being fairly close to 12%, then we're sort of left with like, oh, is primary care okay? Is it not okay? What's driving that? And yeah, after a lot of internal discussion and thinking about this more, I think focusing the work, at least for the beginning, is gonna help us both compare to other states, as you mentioned, and also help us focus on what kinds of actions might we want to take to help support primary care. Do people have other questions, comments?
Judy, this is Jenny, and I agree with you about the definition. Do most other states have two, or do they usually just go with the one?
They just have one. Yeah.
Okay.
So we started with the two because that's what the group that worked with OFM decided on. And, you know, to be fair, that was not a lot of states were working on primary care spend then. So it was a bit of uncharted territory. And I think now, with having a few years behind us and a number of states entering into this, most states just have the narrow. And so that would make us a little bit more comparable to them in that way. Okay, well, if there isn't any other discussion, does somebody want to make a motion to recommend the broad and narrow, or just the narrow definition as the definition of primary care?
Motion to adopt the narrow definition.
I'll second.
Great. Any discussion? So all in favor, please raise your hand on the Zoom portal and we'll count. And I just realized that this counts for you, which is so fun. Last time I think I dug through them, but it looks like 13 people have voted for. I guess we should make sure they're all committee members. Yes. Okay, you can lower your hands, and then anyone who objects to this motion, please raise your hand. Okay, great. We have one. So the motion passes. Thanks for that. This is all very exciting. You can see I have given you an hour back in your day. We thought that this might go shorter, but we also wanted to leave enough time for enough discussion for this. And so I appreciate your time and participation in today's discussion and voting. The recording and summary of this meeting will be posted shortly on our website. I also wanted to note that we're working to finalize the 2024 meeting schedule. Although not yet finalized, we anticipate the next committee meeting will be towards the end of January of 2024, and we hope to share the finalized schedule with you soon. I know that schedules get tricky, and so we are looking at some of our room availability and getting that sorted out. But I hope all of you have happy holidays, and I look forward to seeing you all in our next meeting in 2024. Thank you.
Thank you. Bye.
Thanks, Judy.
Thank
Thank
you.
you.
Bye-bye.
Thank you so much.
Thank you.